Good day to our nursing fundamental students on this second week of remote distance learning, 11th week of the semester. This week we will be discussing the process for assessment of the integument system and wounds. The skin, as you might all well know, is the largest organ system in the body and includes all the covering of the human body, including the hair, skin, nails, and also there are secretory cells within the integument system as well that are important to maintain the integrity of the skin. And this is all part of your anatomy and physiology review that I'm not going to do a lot of time spending because that's your prior knowledge. Okay. And there's another type of breakdown. It's an intentional wound. Sometimes we do things to the skin that can, some are injury, some are intentional. But wounds can be, or breakdown, or wounds can be either open or closed. An open wound is what you see right here on the scalp, where that has been closed by, it looks like staples, which are really not supposed to be used in the head. They should suture that. That's crazy. But anyway, the closed wounds are like abrasions. You know, they don't go deeper than the skin. A closed wound might be a burn on the surface of the skin, a chemical exposure, chemical burn. So those can be closed, cause closed wounds. But when open wounds are usually a penetrating wound. Wounds can be either acute or chronic. Acute are easier to manage, really, and there's often a benefit of recovery or healing with an acute injury. Whereas when you get into chronic wounds, we know several of those, and people with chronic wounds that are non-healing, with a lack of perfusion, the lack of sensation, lack of circulation, they end up getting typically their extremities removed, their toes, their feet, lower extremity, below the knee amputation because of chronic wounds. How about clean wounds? Clean wounds are those wounds we don't want to introduce any more bacteria in, so we would use aseptic technique in clean wounds. Okay, some clean wounds we would use, we apply sterile dressings. We're using sterile gloves because of the nature of the clean wound. Contaminated wounds are sometimes what we call are just wounds that are dirty. They're not really dirty, they're just not sterile. I mean, they're just, we use wet to dry with normal saline. If they're open, and those are typically the ones that are open. We just use wet to dry, keeping the wound bed moist and trying to pull out. And then also, you know, wounds that are chronic wounds are often contaminated wounds. But infected wounds, those become a problem. And they've got to be treated with, if it's a closed wound that's infected, you treat them with antibiotics. If it's an open wound that becomes infected, they might treat them with antibiotics and possibly do a surgical procedure, what we call an incision and drainage of an infected wound. And maybe they may end up with a drain placed to try to do that. And certainly a wound that was once closed, and if it does have infected drainage, called purulent drainage, then they will go in, reopen that up, and do what we call an incision and drainage. And they will often leave a tube, a Jackson Pratt or a Penrose drain within, and suture the edge of the, put a suture line across that. And sometimes they will leave those wounds open. They may close it partially and then let the other part remain open to allow it to heal from the inside out. Those become kind of really large scar wounds, by the way. So If you're worried about that bikini line, there it goes, right there. Okay, how about superficial or partial? Partial or full thickness. When we talk about superficial wounds, scrapes, scratches, but can become infected, by the way. We already talked about that. What happens within the skin? We can have methicillin, we can have the Staph aureus located on the skin become inside the skin cells. It could cause a cellulitis or what we call MRSA within the skin. Okay, and then partial or full thickness, that's when we get into burns. Burns are staged by first and second degree burns are partial, and you get third degree is kind of bridging between partial and full thickness. And of course, for the highest degree of full thickness burns are go clear through all the tissues to and expose the bone, and that's what they call full thickness. And we talked about penetrating wounds, knife or stab wounds, injury wounds. Those can be classified as, and they are also, because of the penetrating, they also, it depends on the type of cut, it often leaves a sharp wound edge or a nice linear line versus a jagged line. Usually when they have those major tears or abrasions, they leave very jagged wound edges, but oftentimes a penetrating wound can leave a very of a piercing object, oftentimes lead a pretty defined wound edge. So anyway, that's interesting about those. Now, we've talked about some of the wounds, and there are many, and we'll get into some of the dressings, really how we manage wounds and the type of dressings. But you'll see a plethora of dressings, 2x2s, 4x4s, gauze, ABD pads, and also the tapes that go with them to secure them. Leukopoor, you might have paper tape, you might have Montgomery straps with a abdominal wound with an ABD pad. So, but anyway, in the wound healing process, this is just, I want to show you this. It's a great example, particularly when you look at the regeneration phase of wound healing. You see that there's different, remember the type of wounds we talked about? We talked about a clean wound, okay, with a nice clean edge on it. And then we can have a sutured wound that closes that. And then when that clean wound is then, when the sutures are removed, the granulations occurred, you just see the lines of where the suture marks. And gradually, those will dissipate as people age. Those little scar lines will disappear in the skin because of a nice fine suture, by the way. By the way, a plastic surgeon, you would not see, if a plastic surgery is going to do surgery right here, you would not see an external suture. You would see, it would be under the skin if it were plastic surgery. So realize that, okay? So then we have, and there's no scars often left really with those. It's just a fine line. It's just a fine incision line. And then we have primary intentional types of wounds and the healing process. If it's a surgical wound, it can be approximated or pulled together is what we call that. And they pull the edges together, and it also helps to reduce scarring when they do that. But in the B section right there, where you see the wound with gaping and irregular wound edges and wound bed, that's the kind, because of its nature, those are often the kind, if they're infected, they leave those open, and that's what those look like. Okay, so that's interesting there. Okay. Now let's look at the secondary intention of the wound healing. Notice the differentiate the categories, remember, of these types of healing process. The secondary intention. There's the primary and there's secondary. Pay attention to what's happening Wound edges are not approximated in secondary intention. There's tissue loss and heals from the inner layer to the surface, okay, like we talked about. And those can leave really large scars. I should have put that on there. The large scars can be left because of those types of wounds. Okay. Then, so we have primary, we have secondary, we have tertiary intention. And granulation tissue, you see, is brought together. Epithelial tissue fills the scar and reduces scarring in the healing process. And sometimes there's delayed closure of the wound edges. Notice here there's an example right here of just a suture line. They may have had a drain in there, just closing part of it and then letting it close, or get any, because it may have been infected, to leave that portion open right there. And also they can, once the infection starts to close, that will pull closer together and that will leave at least a little larger scar. So it doesn't say it's absent of scar, but it reduces scarring in the healing process. Okay, so be able to distinguish those types of healing process: primary, secondary, and tertiary intention in the healing process. Okay. Now, there are the phases of wound healing. This is for you as far as assessing this inner. You need to know the phases of wound healing because of our assessment of a wound as registered nurses, as nursing professionals. There's the first phase, which is the inflammatory phase. It includes both hemostasis. Because of injury to the skin, we get automatic positive feedback mechanisms to maintain hemostasis, and that is the vessels are clotted off, and we also get the immune response, cells within blood and within the in the skin immediately start to impact that area, and so then we get the inflammatory process related to that. Which edema, erythema, pain, by the way, because of the increased inflammation in the site that causes the tenderness and the pain with a wound injury. Okay, so that's temperature, being febrile. A person can have a systemic response by an infection within that inflammatory process that causes a febrile state. And then look at the temperature. We already talked about the migration of white cells. We talked about, because that's the body's normal response to when the body's largest organ system is damaged or penetrated, then the body is going to send all of its defenders, because the first line of defense has been altered. So we get those second and third lines of defense to play in when we have a break in the skin. Okay, then there's the proliferation phase of wound healing. Proliferation, think of cellular proliferation or regeneration. A rapid cellular division occurs between 5 and 21 days as the wound is replaced by good, new, healthy cells, and fibroblasts, connective tissue, migrate to the wound, and they help to form collagen, and that collagen helps to strengthen, re-strengthen, and that's where we talk about where it starts to granulate. We call that starting the granulation. It's where the skin, bottom of the skin is pink, it's moist, and it looks healthy. That's that granulation phase of cellular proliferation. That's the kind of wound bed we want to see if we recognize that a wound is healing properly or healing healthy. Then we will see a nice pink, moist granulation that's free of anything else. No pus, no eschar, none. Just a nice pink. The wound edge might be a little bit deeper pink red, but the wound bottom is a nice, healthy looking pink when we have good, healthy granulation. And then there's the epithelial of the maturation phase. Epithelialization is known as remodeling, the final phase of the healing. And then you get the what happens in remodeling because of the fact of fibrin and collagen working together. They help form the scar to help over a surface wound. That's that process. Over a penetrating wound, you'll see these epithelial remodeling helping to pull that wound edge together. And so that's kind of, and that'll be, that takes, usually depends on the type of wound. That can be several weeks to months, depending on the wound for that remodeling. Okay. And especially the age will impact that. Okay, now let's talk about some of the wound closures. How we protect the wound, because obviously the skin's been damaged, injured, and now it's been exposed to external. You know, the first line of defense is now open. It's not a closed system anymore. So even after, you know, we've done what we can do, seen what the scene, we check the wound edge, then we got to cover that to protect it from further damage, or to allow the environment to be moist, to keep it moist so it helps support wound healing. Okay, there's those two things we do. But you'll see in patients the adhesive strips known as Steri-Strips. They use a skin prep on the skin. You wipe the skin around it so it helps prevent the oils on the skin from causing these to come up. But adhesive strips called Steri-Strips, I've used them myself many times. You just apply them over a small wound, and you pull the edge together, and then you tape it to the other side, going from that same, and then you go from the other side and pull that side together and put it down. And you're making that incision very tight with those Steri-Strips. And then you instruct the patient, don't peel them off. In 7 to 10 days, they'll start peeling off. They can, after day 1, they can go ahead, by the way, after they've had an incision, there's no bathing, there's no soaking for usually a month after they've had an open wound. And before they can ever bathe, it must be granulated and mottled before they can get in submerse. So that's something you gotta teach patients when you're teaching them about these types of wound closures. They may shower with Steri-Strips, but they do not pull them off. They can soap and water everywhere, but they don't peel them off. They just start coming up on their own when the wound begins to close together. Okay, and then there's sutures. Sutures is a mechanical way to help close and bring the skin edges back together, and they're used when they go deep into deep tissue. So there can be multiple layers of suturing to bring the tissues together, particularly in a surgical procedure, going through, separating muscle tissue or other tissues that going through membranes, multiple membranes through the abdominal cavity. They will have to suture at each membrane level to close that off, or else you get a hernia, by the way, if they don't close it right. But you get abdominal organs poking up through the perineum, so it's not good. But anyway, the example of closed organ is when we do what they do in anastomosis within when they connect tissue together. Remember when I talked about that in the GI section? When they do a takedown, they'll do a reanastomosis of the bowel. That's what we refer to as bringing an organ tissue together, particularly like the colon is a classic organ that they use that, and we use that term for. Those absorbent sutures will gradually dissolve when that anastomosis is healed. And those are usually 14 to 20 days is when they'll start to dissolve, and they're normal to body tissue. And by the way, those are sterile. They come in a pack, a sterile foil pack, and they're dropped onto the sterile field by a nurse, such as you. That's an example where they will drop on the tray suture material with types of needles that come with those sutures. I won't get into those needles. You don't need to know all those. But then there's the non-absorbent sutures that you see really commonly, and those have to be removed. They usually can be seen on the skin. Those examples of the skin, the sutures, what we showed that were above the skin, the slide where I showed, this is a plastic surgeon. They would do under the skin. They wouldn't have sutures over the skin. They would do it under, so you'd never see the sutures. Plastic surgery, that's what they do. But when you have just general non-absorbent sutures, they're over the top of the skin, and those will be all types of suture. They're strong, and they're often areas where they can put those sites for most wounds, whether it's an area where it's very prominent, like say a bony prominence that's sutured, so like your chin, because you bump your chin, or over the eye where somebody's got hit real hard with something and it put a laceration over their eye. Those bony prominences, they have to be closed with a suture. And then we'll talk about the next level. But those have to be removed, usually by us, 7 to 10 days later. If they are not removed, they will start to get embedded into the granulating tissue, and they become very tender to take out. And they are hurt, and the wound edge is inflamed. So as soon as that incision line starts to really look pink and granulate and it's pulled together, those sutures need to come out, okay? Otherwise, they can create problems. No more than 10 days, those non-absorbent superficial sutures will come off of the skin using suture removal scissors to do that, okay? And we have those in par carts, and every hospital has those. And then look at the surgical staples. You can see these done with, particularly over the areas, the surface areas, not the bony prominences, but surface areas of the skin, where there's tissue underneath, soft tissue underneath, particularly wounds of over the arms, legs, the abdominal cavity is classic. They say the scalp, but that picture of the scalp staple, that's the first time I've ever seen it. I usually see suture in the scalp, so it leaves a nicer wound line, and also the hair grows together a little nicer when it's a suture, by the way, versus staple. But wounds on the hands, feet, or neck are never stapled, so notice that that's underlined, so pay attention to that. Where are staples? Can they be applied? And where are they not going to be applied? That's probably, of these types of wound closures, that's the one you need to be aware of, where it may be and where it may be not appropriate to use those, okay? So think of it that way. Also, then we get into closures. Now we talked about some wounds aren't perfectly closed. They may be left open a little bit because of a drain or drainage that needs to come out. And there's types of drainage, the terms we use, and these are terms that you need to know. There are pictures in your text that give examples of the color of exudate or drainage, in other words. Serous exudate or drainage. Serous is the term for, serous is like the color of the plasma portion of blood. It's kind of a straw colored, but it's a little thicker, but it's normal. It's serous. It's the the wound, the drainage is healing because the serous drainage is just plasma drainage through the tissue, and so it's not as significant. And when there's a sanguinous blood, that is frank blood drainage. When it's sanguinous, it is blood, dark red, thick blood non-oxygenated blood. It is dark, and so that is what we call sanguinous. And then there's a combination where it's not quite straw colored. We call it serous sanguinous. It's a pink, it's a dark pink, and there could be striations of a little bit of blood of the sanguinous within the serous component, and we call that serous sanguinous. There's a particular part of the female reproductive system, the uterine cycle, where the drainage can be defined in these very exact ways from when that drainage starts, menses starts, and when it ends. You see these different changes. Now, when we get to purulent drainage right here, this one right here, where can I get this right here, the purulent drainage right there, that is where you start to see there can be infection. That's the classic thing, you know there's an infection in the wound. There are several signs of a wound infection, but having purulent drainage is one. Having a blood count of white cells, elevated white cell count, and also probably having a fever. But those will go together in an affected wound. They're pus-like, and in a purosanguinous exudate is where we have the serous drainage, but it's got pus in it, and it also has a very strong odor when it's infected and it's purulent. It has a very strong odor in that exudate, and you would certainly notify. You'd get a swab culture of that, and or have the lab get a swab culture, notify the provider that there is pus in there. If they're not aware of that, then they should be notified. There's purulent drainage. So anyway, that's an important factor to consider. Okay. Now let's look at the complications of wounds. Look at the pictures I've inserted in these slides. That wound that's open there. It's the bowel is protruding out. It's gone through the incision line, and that incision is opened up. We call that dehiscence. And that's often caused from either swelling, or could be caused because there's an infection, and that usually is what causes those tears within the wound to reopen, to open back up, and that's a complication of particularly a surgical wound. When a surgical wound opens up like this, that's a complication. Okay, it shouldn't occur. It's abnormal, and so they would consider that there's something else going on to precipitate the reopening of the tissue after it's been closed. Okay, so and then evisceration is another term we like to use when dealing with how a wound, when it eviscerates, it invades another space. And then we have fistula, the types of fistulas where a tissue will protrude from one area where it's supposed to reside, and it will push through another area of tissue. That's called a fistula. And you can see there's a rectal fistula, a rectovaginal fistula in this picture here, which can be, those are more common today because of the, let's say, how do we say that, the practice patterns of people in that area of the body. You start to see more of those issues going on. Okay, so in the ER they see all sorts of things like that because of what people do. So those fistulas might be more common, but that's when, certainly when a tissue that resides in an area is invaded. It's a fistula. In some areas it'll be a fistula and there's a tear between the space that causes a connection between those. Is really because a hernia is when the tissue itself just protrudes outside. We don't have that in here, but a hernia can be a complication. This is kind of this bowel protruding right here. That can be considered maybe a possible form of hernia, but it's external to the body. Most hernias lie within tissue inside, and they go out of their defined space because there might be a reception. The membrane covering that might have a tear in it, and then like the bowel wall might protrude out, cause an umbilical hernia. You got the inguinal canal, and a cord might come out because of straining. It might tear the cord that holds vessels and nerves and within that area, and that might cause an inguinal hernia, or of course ventral hernias are a little higher up and in the low abdominal wall. Those can all be caused from straining or heavy lifting. Okay. Thinker question number 2. I will let you read this. I will give you time to do this, but I'm just going to sit here for a minute so you can think about this particular question. This would be a good break time from our class right now. Okay, if you derive the right answer, you will say B. A centimeter separation of wound edges is only in the center of a surgical incision. Okay. If there's even a large separation, there's no internal viscera to protrude. Okay. That's on a superficial area. That doesn't ever happen. So